Well, we have our next presenter, and it gives me great pleasure to introduce Dr. Lauren Kelly, who is an assistant professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine. And she has a passion and expertise for the care of older adults in serious illness with substance use disorders and chronic pain. Her clinical practice is in supportive oncology at Mount Sinai's Tisch Cancer Center and the Mount Sinai Behavioral Health Center, where she started the SAGE Care Program, a co-management model for older adults with substance use disorder and geriatric care needs. She's been quite involved in local and national educational efforts, health systems leadership, and state policy to increase access to quality geriatrics and palliative care for patients with substance use disorder. And you're in for a real treat because she has really become an expert in this area. And I welcome you, Dr. Kelly, and thank you very much for being here.
Thanks so much, Helen. Good afternoon, everyone. It's great to be here today to talk to you about the important topic of substance use disorder care in geriatrics and palliative medicine. This will be a lot to pack into 40 minutes, but I'm going to do my best. I have no conflicts of interest to disclose. Specific objectives for today are to define the scope of substance use in our population, to review screening and diagnosing, and then to discuss interdisciplinary principles of management. So why does this matter? Our patients in geriatrics and palliative care are already quite vulnerable, but when you add substance use disorder and chronic pain into the mix, which is highly prevalent, this becomes an even more vulnerable population that requires special tools and skills. We're already all caring for patients with substance use disorders. They're extremely common and becoming even more prevalent as time goes on with the aging of the baby boomer cohort. This epidemiologic data are likely underestimates. I'll pause to just let these numbers kind of sink in. Alcohol is the most common substance, with about a quarter of older adults with a history of binge drinking. Next, you have prescription drugs, with about a quarter or so of older adults on psychoactive medication that has misuse potential. And then a smaller population, about 10 to 15%, using illicit drugs. A good chunk of that is cannabis, but a lot of other substances too, which we'll talk about today. With chronic pain on opioids, about a quarter of those patients develop risky use, and about a tenth develop opioid use disorder. And the numbers look pretty similar among patients with cancer who are in treatment for pain. So the numbers of substance use disorder are quite high in the GeriPal population. You might be missing this. So substance use disorders are under-detected. We're not always screening for these routinely. They're under-recognized as a cause of a lot of different medical problems that we see, including things like falls, cognitive decline, and other medical problems. Alcohol and benzo withdrawal are also under-recognized clinically. And the good news is that these are all treatable conditions, and impairments that we see in many cases can be reversed or remedied to a significant degree. Unfortunately, drug and alcohol deaths are on the rise. We've seen death rates from drug overdose in adults 65 plus more than triple in the past 2 decades. And there has also been a significant increase in alcohol-related deaths. More recent data, specifically around opioid overdoses, has been plateauing, which is great news. Our public health efforts have been working, but that the problem is still of very high magnitude and affects a lot of our patients. So it's important to note that there's a lot of gender and racial and ethnic disparities that we're seeing in this data as well. Why is this happening? So there's a few hypotheses about why we're seeing this increase in substance use disorder. The COVID-19 pandemic definitely contributed to worsening in social isolation and mental health in older adults who are more vulnerable to this already. Additionally, as I mentioned, the baby boomer generation is aging, and they were historically exposed to drugs and alcohol at younger ages, and they're bringing their substance use disorders into older adulthood. About half of the baby boomer cohort report lifetime substance use, and that's more than double the generation that preceded them. Lastly, the drug supply has become increasingly dangerous, tainted with adulterants, things like xylazine and other chemicals that are ending up in the supply. And can be really destabilizing for older adults that may have been using substances more stably in the long term. So changes in the supply definitely are contributing. In general, we know that older adults and folks who are frail face more adverse effects and higher morbidity and mortality related to substances. And even with a stable pattern of use, we can see functional impairment dramatically increasing with advancing age. So this slide lists all of the different adverse effects of substances that we're all aware of. So alcohol being most common is associated with all types of dementia, mood disorders, unintentional injuries and falls. And then benzodiazepines, we all know, are associated with cognitive impairment, delirium, falls. Of note, the boards will always encourage you to taper off of benzos rather than continue them in the long term. And that's for good reason related to a lot of the long-term side effects that we see. Opioids are really lethal. So higher overdose rates in older adults and greater all-cause mortality. Cannabis use is on the rise. It's a lot more potent. It can cause somnolence, impaired motor function, falls, and the cognitive impact is really not clear. There's definitely concern that has been brought up, and there are also some studies looking at the neuroprotective effects of different cannabinoids. So again, the jury out on that from a cognitive perspective. There is a higher burden of geriatric syndromes in patients with substance use disorder. Older adults with substance use disorder basically experience an accelerated process of aging. They have higher rates of mobility impairment, falls, frailty, cognitive impairment. It's kind of striking. Nearly 2/3 of patients with substance use disorder are screened positive for cognitive impairment, which is strikingly higher than the general population. So, an important thing to be aware of. Another slide here showing that substances are, this shows increased mortality related to falls over time. And substances are absolutely contributing to falls mortality. There was a recent New York Times piece about this actually last week, I think. This is fundamentally an equity issue. There are higher rates of substance use disorder and associated morbidity and mortality in racially and ethnically minoritized groups. This includes harms of criminalization of substance use, incarceration, also things like medical undertreatment of pain and other conditions among patients with substance use disorder. But it's also a capacity issue, and addiction specialists can't manage this on their own. The overwhelming majority of people with substance use disorder, around 80 to 90%, are not getting any treatment, which means there's so much more that we can be doing for our patients. So this is a tremendous opportunity for prevention and reduction of morbidity and mortality among older adults. And this is what we're all about in geriatrics. On this slide, I'd just like to highlight several relevant risk factors for substance use disorder. So things such as prior history of substance use disorder or mental health diagnosis, major changes in life circumstances like involuntary retirement, financial stress, bereavement of a spouse or loss of housing, and also major medical issues like chronic pain. We see a high association between substance use and chronic pain, as well as multimorbidity or being a caregiver to a sick loved one. There are a number of protective factors, which include partnership, having a spouse, good social support, ability to live independently, having a sense of identity and purpose, and also developing a substance use disorder later in life. Folks who develop younger onset substance use disorder usually means there's more of a genetic predisposition and can be a bit harder to treat, whereas an older adult onset is more likely related to modifiable things like stressful life events. So yes, we should be managing this in geriatric primary care, but what about in palliative care? In palliative care, we don't typically do primary management of conditions beyond symptom management, but the reality is that palliative care becomes primary care for patients with serious illness. And as patients are progressing in their illness, palliative care clinicians and interdisciplinary team members need to have facility in the treatment of substance use disorders. And this is not the current model of care that we have. So patients suffer a lot of care fragmentation and poor outcomes because of this. The good news is that GeriPal and addiction already have a lot in common, like things like harm reduction and shared decision making. We're often in situations in both of these fields where the ideal is not achievable, or even the standard of care might be ill advised because of a patient's unique circumstances and goals. So I like to say that in GeriPal and addiction, we're living in the real world with our patients. Let's talk briefly about stigma. We're all aware of it, but like anything else, practice makes perfect. So, data shows that the more experience we have with patients with substance use disorders, the more acclimated we are to recognizing and treating them, and stigma reduces drastically in that setting. Being familiar with terminology is really important. Substance use does not equal a substance use disorder. So there's three different ways to think about this. You have recreational use, which is not causing any apparent medical, social, or legal issues for a person. For example, having a glass of wine once or twice a week, that's not an issue. When use becomes risky, that's when we're noticing or having significant concern for harms related to the substance use. For example, taking prescription substances differently than they were prescribed, or using unhealthy amounts of alcohol, which we'll define later, and using risky illicit substances. Substance use disorder is characterized by a problematic pattern, a pattern of substance use that leads to problems or distress. So it's a chronic condition, and it can get better for a little while, and then it can relapse, and that's sort of the nature of it. And it reflects an altered chemistry in the brain that causes compulsive behavior around substance use. And there's a complex interplay of factors that influence addiction. We mentioned genetics already. Almost 60% of most of the substance use disorders that we study have genetic components. But we know that there's also a strong component of the environment, of our life experiences that contribute to that as well. And again, really important to know that substance use is treatable and that we have therapies for substance use disorder that are as efficacious, if not more so, than those for other chronic conditions. Language really matters, and this is the case for every member of the healthcare team that cares for patients. So, especially anyone who's documenting in the medical chart. All of the terms on the left in red are associated with stigma. Abuse used to be an accepted term, but we no longer use that. We use person-centered language, so a person with substance use disorder, not an addict. And things like negative or positive or unexpected urine toxicology, not using words like clean or dirty that have a lot of judgment associated with them. I briefly showed this slide to share that using words like substance abuser as opposed to person with a substance use disorder can actually alter the course of how patients are cared for. Sorry. Just okie doke. Apologize for that. So people actually are getting worse care when they are labeled with stigmatizing language, which is maybe not surprising. Moving on to screening. So, screening for substance use disorder is a routine part of any initial H&P under the social history section of your interview with patients. SAMHSA recommends it annually and with any major life changes. And this can be collected by anyone, really, the medical assistants or the nurses on triage. Here I've listed our single item screeners for alcohol and drugs, and then a two-item screener called the TICS that we have been using a lot at Sinai. There are many others. The point is you want to pick a consistent screener that you're using, within your department or, from a QI perspective to be consistent and use them with all of your patients. Note here that cutoffs for alcohol are different in older adults. So, unhealthy use is defined as 4 or more drinks in a sitting, also called a binge, or greater than 7 drinks in a week. So, it's recommended to have no more than 1 drink nightly on average. And note these are cutoffs for healthy older adults who are on few medications. With more comorbidity and polypharmacy, some argue that the threshold should be even lower and that maybe no level of alcohol is safe. But again, we live in the real world with our patients. We get the information and we counsel on risk, but we don't judge. We don't judge people. Beyond screening, it's important to focus more on dialogue where you learn a lot from the patient. So you want to start by exploring, by getting more information in a non-judgmental way, assuming that the substance has had some benefit for the person. They're not doing it just because. Clearly, there's some relief, or maybe they're using it for alcohol for sleep, or maybe actually maybe they will admit that there is a euphoric component to their heroin use. So really, just getting a sense of what it is that people are getting out of their substance use. I think general open-ended questions are best. So things like, what's your relationship with X substance? How does it impact you? How does it fit into your life? Can you tell me more about your story and how you use substances? And you really want to normalize the conversation, be curious, and give the patient space to teach you. I've been doing this for a few years, and I still learn new things from my patients every day. And if you're uncomfortable talking about this, the patient's going to feel uncomfortable being asked about it. So really try to model comfort in your voice, comfort in your body language. Context is important too. So you want to ask questions after you've developed a little bit of rapport. Similarly, you can't get a detailed history of someone's substance use if they're in acute pain in the ER. You need to sort of adjust your history taking to the situation, but you can always come back to this. And it's also never too late to ask someone about their substance use, even if you've known them for a long time and have never really talked about it before. These are some more in-depth questions while taking a substance use history. Questions like, have you had experiences where you felt like you needed to cut down and you couldn't? Have you had experiences where this impacted your career or school or relationships or maybe caused legal trouble? And then if issues come up, how can we try to center your health? And really talking these things out, getting to know the patient, understanding how substance use has created issues for them, and what are the important priorities for that person. I think this is, the beginning of motivational interviewing, and MI, or motivational interviewing, happens over time. A quick detour just to say that substance use history screening and opioid risk assessment are distinct, but related processes. So we do opioid risk assessment to try and predict which patients are at risk for opioid misuse or risky use. And this can help you implement safer prescribing practices. There are different tools. There's many of them. You may be familiar with things like OUDORT, or the urine toxicology screening. And these are really variably utilized by providers. The most important thing to know is the factors that are most associated with risky use are history of opioid use disorder, history of a non-opioid substance use disorder, and a mental health diagnosis, or patients who are on psychiatric medication. And this is all information we can glean from a basic interview to help guide safer prescribing practices. We think of standard precautions for all of our patients when we're prescribing controlled meds and opioids as well. Um, Routine substance use screening, prescription drug monitoring, PDMP checks, urine checks, providing naloxone as a harm reduction measure. Um, these are all really kind of standard um, things that we do for our patients. Always assessing for taper opportunities and making sure that the treatment continues to support functional goals. So if you're in a situation where you're escalating opioids, there's no functional improvement, it's really a moment to really pause and say, is this what we should be doing? Should we be thinking about a taper? And I try to educate my patients even before I start them on opioids that we will always be assessing for opportunities to reduce the utilization. In patients who are higher risk, who require controlled meds, for example, someone with a substance use disorder, we always use extra layer of precautions like smaller fills, more frequent visits, and considering things like buprenorphine when that may be appropriate. When using urine screening, I personally don't bring it up until the end of the visit after the plan of care has been discussed. This way, the patient doesn't think that their plan of care is going to depend on what their urine shows. If opioids are clinically indicated, then they should be prescribed. And you want to emphasize that this is a protocol that you use for all patients, not selectively, and that the reason is for safety. And that no matter what the results show, that you'll work together with the patient. Um, my opinion is that urine testing is really important as a safety issue for older adults and seriously ill folks, given how severe the consequences can be with polysubstance use in these populations. And I think it really gives you an opportunity for harm reduction counseling when you do find unexpected results. So it's a normal part of my practice. In our practice, we don't use opioid agreements that we ask patients to sign. We feel like that's pretty putative and there's not really compelling evidence that they work. Instead, we discuss and provide a copy for patients about our opioid guidelines, which include things like expectations for having routine visits, periodic testing of the urine, no self-titration of medication, using the same pharmacy, being the only prescriber, etc. Moving into diagnosis of substance use. So, to diagnose substance use disorder, we use the DSM-5 criteria. There are 11 symptoms and categories, and you must meet two of the 11 DSM-5 criteria to have a substance use disorder. And then the severity, whether it's mild, moderate, severe, depends on how many of these criteria are actually present. It's a bit tough to remember. So we have a shorthand, the four C's, which approximates the DSM-5 criteria and are a lot easier to remember. So compulsive use, so using substances despite hazards, craving, strong urge to use a substance, consequences, so continued use despite harm, and issues of control. So difficulty adhering to the prescription instructions, using more than intended, things like that. This just highlights deeper questions that we can ask when we're collecting a substance use disorder history. I'm going to move through this since we don't have a lot of time. We've already covered how substance use disorder can be more subtle in older adults. Things like mood changes, cognitive changes, or functional decline, more falls. Always have this on your differential. Next, we'll cover the principles of management. So first we'll talk about non-medical treatments, and then we'll talk about medical treatments. So starting with motivational interviewing, MI is defined as a type of facilitated conversation that moves patients towards positive change. And the basic principle is to evoke a person's own reasons for change and then mirror that back to them. So, for example, saying something like, I hear that your drinking has caused a lot of issues between you and your wife, and that it's really important for you to strengthen that relationship. How do you think we can work on that? Or you can ask, on a scale of 1 to 10, 10 is you're absolutely ready for change. How ready are you to make a change? And if the person says, oh, I'm a 3 out of 10, well, what makes them a 3 and not a 0? So this really does take time over multiple visits, and any team member can engage patients in motivational interviewing, including clinicians, nurses, social work staff. Um, and if you want to learn more about MI, there's a lot of workshops online that you can use to practice this further. This is the stages of change model, which is crucial in motivational interviewing. So, whether a patient is in pre-contemplative or contemplated or preparation phase or maintenance phase, this is going to shape what's possible for treatment because patients are not going to accept treatments that don't match their own goals. We often will try to say this is what you should do, and we give them a bunch of homework, and then they come back and we're upset that they didn't do any of that. But that's really not what we should be aiming for. Um, we don't have enough time to go through each of these, but the skills of MI are skills that we're well trained in as geriatricians and palliative med docs. ORS is the mnemonic for open questions, affirmations, reflective listening, summarizing. So this, for many of you who've done Vital Talk or Geri Talk, this sounds very similar. MI can be challenging in older adults. They often feel like it's too late for them to change, or maybe they feel like they're already sick enough. So, what's there to be gained? And some older adults use substances out of loneliness and bereavement, which increase with age, with dwindling social networks. So, it can be really hard to have these conversations. But I think there's definitely some tips that I think about when talking with older adults. So, we tell patients that we're increasing their longevity and the quality of their life, and that while it's not a quick fix, we know that when people, stop using things like alcohol or tobacco, that they really feel changes, positive changes in their body. Feel maybe younger off of alcohol, or maybe they're sleeping better. Even with a few months of abstinence, there's a lot of change. And we're also promoting self-worth and autonomy, building confidence, improving isolation and depression by helping them build deeper community and engagement through peer programming and things like psychotherapy and group therapy. The most successful interventions for substance use involve peers. In other words, people who've gone through the same thing, who are in a similar age range, and really addressing issues of what are people doing in their leisure time, because boredom is often, fuel for substance use, and really getting them more social. Getting up and getting involved is I think, the secret, or not so secret, to recovery for many people. I'm going to skip this. So, SBIRT, you may have heard of SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment for Substance Use, which is a national evidence-based approach that's funded through SAMHSA. And even 10 minutes on this can make a measurable difference. Mostly this is helpful for folks with risky use or with a mild substance use disorder. It's less helpful for full-fledged substance use disorder, where you're going to need a more comprehensive approach. But basically, it involves screening for substance use. You do a brief intervention, you use motivational interviewing to see where they're at, and then you can refer them to treatment and even propose potentially starting some medications. And we'll talk about both treatment referrals and meds in more detail. I just want to highlight here that social work involvement, when possible, cannot be overstated. It's really, really important. They help us get our patients access to really important things like insurance, transportation, housing. They help us get our patients into therapy, into peer support programs, into adult day programs, senior centers. And again, the psychosocial elements are so critical in substance use. This is an important slide on referring to treatment. You want to try to match your referral with the level of care that the patient needs and that they're prepared to accept. So first, assess safety. If patient's coming off a substance that has a withdrawal syndrome associated with it, like alcohol and benzodiazepines, you definitely want to consider, the risk of that, and if they require inpatient treatment. In some cases, the emergency department might be the safest option for them. if the patient has acute intoxication, or if you're concerned for an overdose, or if they have some type of decompensated medical and or psychiatric issue related to their substance use. And if you are referring them to acute care, you definitely want to do a warm handoff in this situation. If you're going to be managing in the community, because you feel it's safe, it's reasonable to begin with a referral to outpatient addiction assessment, where needs can be further assessed if that's available to you. There are a lot of different outpatient options in treatment. So we have psychotherapy, we have peer support groups, and then, of course, there are clinics for medication prescribing. There are more intensive outpatient groups called IOPs, intensive outpatient programs. Those meet 3 to 4 times per week for several hours per day. And they typically include things like group therapy and medication prescribing. More intensive than that is partial hospitalization and residential programs where patients are actually on site living while getting treatment. And then, of course, the most resource intensive is inpatient care and detox services. When you're not sure, you can refer patients to a comprehensive treatment center if that's available to you, where they can be evaluated and directed to tailored treatment. But a lot of the patients that we see, many of them aren't ready to become addiction patients, right? Maybe they're more willing to participate in lower intensity outpatient care, such as peer support groups like AA or NA or Smart Recovery. And maybe also even counseling or therapy, which is definitely a place to start. And if that's where they're at, then that's where you meet them. Note that harm reduction services are always an option at any level of care, as either primary treatment or to supplement any other plan of care. We'll talk more about harm reduction. So even if things are a little better, that's great. Harm reduction approach acknowledges that substance use is a reality. It always will be. And the approach involves understanding inequities and biases. And it's collaborative, it's not coercive, and it really empowers patients and helps give them a voice. There are many different harm reduction strategies, and this is truly an interdisciplinary sport. So medication prescribing is the only harm reduction item that requires a prescription pad, a clinician. So members of the IDT, including social work, nursing, or behavioral health professionals, can refer patients for substance use treatment, can counsel patients about harm reduction clinics, drop-in centers, syringe exchange programs where those are available, and also discuss safe drug use. So, such as never using alone, there's a hotline, never use alone, using sterile works for injection drugs, things like that. Also, pharmacists get involved in this a lot, can counsel patients on naloxone. We already spoke about social work and the really crucial role that they play. Referrals to treatment, again, often made with the assistance of our social work colleagues, but providers should also feel empowered to directly refer patients and give patients resources as well. Again, all those different levels of care that we spoke about. This is the SAMHSA treatment locator, which allows you to search by desired location and by level of care that you're looking for. And you can plug in their insurance actually to help you decide where you can refer them. A quick word on psych interventions, which are really part of the backbone of substance use treatment and are offered at all levels of care from inpatient to outpatient. We have individual therapy, which sometimes can be a bit harder to access, as you all may be aware. Group therapy is most common, and that's where group dynamics are actually part of the agent of change. Usually these are free to access, offered in different, community health centers and comprehensive programs. Sometimes you have to shop around to find a fit, but there really is, again, that important social and peer support element that makes these groups effective. We also spoke about mutual or peer help groups, so led by peers. And classically, we have AA and NA, which are more sort of abstinence-based models. And then there's definitely more room around harm reduction in groups like Smart Recovery, which there's some resources here. I'll just say that it's really important to involve caregivers and folks around the patient to improve the success of your interventions to the extent that the patient allows you to do that. Um, Individual therapy, I'll just say that mostly focuses on cognitive behavioral therapy model, which is the most evaluated of the psychotherapy options in addiction. CBT focus on cognitions and behaviors, as the name suggests. And I really like this phrase, catch it, check it, change it, which describes how we recognize the triggers and cues, we process them with good coping skills and then anticipate or try to prevent those situations. The way that the brain becomes wired in advanced addiction means that there's a lot of reactive behavior happening, not a lot of frontal lobe processing of what we're doing. And so this is a really helpful strategy to pause. Um, this is some information on other types of psychosocial interventions. I'll just highlight here contingency management. One of the most effective treatments. It involves rewarding positive behaviors, usually with monetary reward, and has been something really the most effective thing in stimulant use disorders. So I'll just highlight that here. It is happening in certain areas in VA programs, but it's not widespread. Um, Just a few short words on insurance barriers. So, getting addiction care when you have Medicare is often a challenge. Medicare, unlike other insurances like Medicaid and commercial insurances, is not obligated to offer parity protections for substance use disorder care. In other words, treating substance use disorder just like any other chronic condition, Medicare is not obligated to do that. It's amazing. But it leads to a lot of access issues. Not all providers are reimbursed for substance use care under Medicare, such as addiction counselors. Multiple levels of care are not accessible to patients on Medicare, so like intensive outpatient programs, certain ones. Residential care is universally unavailable to Medicare patients. And then detox facilities. Medicare beneficiaries can only access hospital associated detoxes and not community-based detoxes. So again, this really limits access. There's also really high copays for medications. Part D does not it's not a protected class of drug, substance use medications. And so we often see that they're very high copays. Medicaid does cover a majority of addiction care, but the enforcement of minimum standards in Medicaid really vary from state to state pretty widely. In general, all payers can do better on medication reimbursement, including getting rid of prior authorizations for these treatments, which are standard of care. Okay, rounding this out, the next 16 slides, I won't be able to go through each in detail, but I just want you to have these as a reference for treatments for substance use disorder. They're not comprehensive. They don't include all substance use disorder treatments, just the most common and the most effective medications, and then tips on using these in geriatrics and palliative. There are three key meds that I personally want to encourage you to use more of. So if you take away anything from this part of the lecture, it's these three: buprenorphine, naltrexone, and varenicline. A couple quick notes for buprenorphine and opioid use disorder. It's very effective and a life-saving treatment in OUD. It cuts opioid-related deaths by more than half. It's safer than methadone, and it's definitely becoming a preferred treatment in older adults, including for pain. We're seeing the VA is saying that buprenorphine is a first-line opioid treatment where opioids are required for chronic pain. It has better tolerability, better safety. And so hopefully you are all aware that it no longer requires an X waiver that was eliminated. Anyone can prescribe this. So I hope you are and you're thinking about it. For opioid use disorder, buprenorphine is a partial opioid agonist. Dose ranges are from 16 to 32 milligrams typically. Starting it, there's two main pathways for initiation, the traditional and the low dose initiation. We use low dose initiation most commonly, including in patients with chronic pain and opioid dependence who we want to transition to buprenorphine. So that's low dose initiation. For methadone, there has been updated federal guidance that holds a lot of promise to increase access. It includes more flexibility on things like telehealth and looser restrictions around take homes that patients can get. But that being said, regulations do remain strict. Methadone can only be prescribed to someone with OUD in an opioid treatment program. I really have seen patients with active OUD started on methadone inpatient without awareness of laws, without continuity of care, connecting folks to outpatient. So we really need to do better with transitioning patients safely across care settings when we're starting them on methadone. In the geriatric population, to minimize adverse drug events like sedation and falls, we do often consider older adults for dose splitting. So having their methadone given twice a day, for example, rather than all at once, particularly if they're on high dose regimens or if they're using methadone in combination with benzodiazepines or other controlled substances that increase risk. Older adults do really well in opioid treatment programs. They have better retention than younger folks, which may be a surprise. This is a slide on treatments for opioid withdrawal. We'll kind of pass over this. Open evidence can tell you all of this now, but here's my slide. Regarding coexisting pain and OUD, would like to point here to this paper on consensus management of patients with pain and OUD from JAMA in 2021. It's a great read on this important topic. There are very few guidelines to direct managing pain and OUD. There's some recent systematic review that I'm happy to share if folks are more interested in this. And I can also talk more about this in future CME lectures. So let me know if you want to hear more about this in the future. For alcohol use disorder, naltrexone is safe and it's the most effective treatment we have, and it's very easy to prescribe in primary care. I want you to read more about it. Usually we start at 25 milligrams a day and increase to the therapeutic dose of 50 milligrams if they're tolerating. Just a couple more slides. Acamprosate for AUD, I will just say it's not very effective and it can be difficult to adhere to 3 times daily, but it does remain an option. Regarding alcohol withdrawal, traditionally we've seen longer acting benzodiazepines used like Librium and diazepam. However, lorazepam may be preferred in older adults because it has a shorter half-life, less sustained adverse effects. And there's also some details here about doing an ambulatory withdrawal taper, which can be effective in the appropriate patient. So I'll leave those slides for you to review as well. Just to say on this slide, there are really important health effects of quitting tobacco, something that may be tested on the boards. We can see significant reductions in things like MI, CVA, and various types of cancer. Varenicline, also known as Chantix, is an amazing tool. It's the most effective treatment we have, and you should prescribe it for your patients. It's renally dosed, and it does have some side effects, but those are generally well tolerated. I'm going to skip this. Sedative hypnotic use disorder. So benzos, people grasp on very tightly to their benzos. This is a whole other topic that I'm happy to share more about. But tapering, we usually proceed slowly, 5 to 10% per week or 25% every 2 weeks. And you really have to go slowly towards the end. Note that more rapid tapers can be done, but sometimes requires inpatient monitoring. And these are some important pointers on psychoeducation for benzotapers. I'll let you read through this later. I want to make sure we have time at least for a few questions. There's very little evidence base for pharmacotherapy for stimulant use disorder. Some evidence for mirtazapine and bupropion, but the best candidates for neurostimulants, things like Ritalin and Adderall, are really people that have clear ADHD history, and ADHD does commonly co-occur with other substance use disorders. And we spoke a little bit about cannabis. So last slide is just to say this is not a niche issue. Primary treatment of substance use disorder should be standard in geriatrics and primary care, and it's an expected competency in palliative care as well. I'll take a question if I have a time.
Thank you, Lauren, for quite a comprehensive review. And some of these questions you might have already addressed. There's one question Who are other team members or resources that I should involve in supporting patients with substance use disorder? I feel ill prepared to manage patients.
Yeah. Social work colleagues for sure, for referrals and for supports, for all the different psychosocial elements. If you can try to meet and get to know who your addiction colleagues are within your institution, or even beyond, if you have to reach out further because it's not present in your institution, I definitely encourage you to do that. The websites I've shared, SAMHSA, treatment locators, a lot of good resources there. But yeah, there's all different types of IDT involvement in the care of patients with substance use disorder. I think we talked a little bit about that throughout the
Yeah.
lecture.
Yes, agreed. And then the last question, how do I become more facile with motivational interviewing?
Yeah, so there are workshops. So if you just Google motivational interview workshops, some of them come at a cost.
Mm,
Some of them, I think you can find ones that are very low cost or free. But I would encourage you to just look it up online. But there's a lot of material out there on that. Um, Hopefully that helps. And you can reach out to me if if you're having trouble.
thank you. Thank you again, Lauren, for your wonderful presentation. Really a lot of resources and tips. Um, and I know the participants really appreciated your presentation. Thank you.
Thanks.